And in my second session, what I was going to do, what I'm still going to do, I'm going to talk about different concepts of health and why QALY type measures are needed, how it could be used, how you could make it operational, first of all, by coming up with a suitable descriptive system, and secondly, how you would deal with the rather difficult valuation issues involved. Okay, so this is what I intend to do, and it won't surprise me one little bit if we don't get it through it all this afternoon, but I'll try. I think the main thing about alternative concepts of health that I want to concentrate on is simply that biomedical ideas about health, which are to do with, you know, the measurement of blood pressure or gamma globulin counts or the amount of flexion you can get in a muscle or something, they're very important in clinical medicine, because they're very useful for diagnostic purposes, and they're very useful for measuring effectiveness in the particular specialty that you're in. Okay, that's fine, these biomedical measures. And of course, the survival rates are also important. But there's another way of looking at this whole thing, which is not to do with the way different bits of the body function, but the way people live. Okay? And these are different concepts, fundamentally different concepts. Now, I started life in the social sciences. I have to keep on reminding myself that economics is a social science. And so from that point of view, what one says that the value of healthcare, if the value of healthcare derives from its capacity to improve people's health, then we need a notion of health that is based upon individuals' capacity to fulfill their life plans. Okay, coming back to an earlier discussion which we touched on briefly. And so consequently you finish up saying, well, the important concept of health to use is some combination of the length and quality of people's lives. And that you say, a healthy person has a good prospect of a long and healthy life, and an ill person or an unhealthy person has a prospect only of a short and or rather poor quality of life. So, and we want to measure the effectiveness of healthcare by asking, what does it contribute to the length of people's lives, and what does it contribute to the quality of people's lives? And all this stuff about gripping things and having pain and whatnot, that's part of it, but that's all got to be put in a much broader setting. And the broader setting is about quality adjusted life expectancy. Now, and that's what I want. So, well, the first thing does that idea grab you okay? Because if it does, as an idea, we then go on with this. That's all very well as an idea, but how the hell are you going to do it? Okay, and then I'll get on to how I think we have to do it and how I've done it, as it were. I've done it to my satisfaction, not to anybody else's, but I've done it to my satisfaction. So I'll give you an opportunity to see why I'm so pleased with myself. Okay, but the idea, okay, right, okay. So the idea is okay. That's half the battle, really. Right, so I'll skip on a little bit down a bit. Now, if we're going to compare the cost effectiveness of very different kinds of things, we need an outcome measure which can be applied to different conditions, different treatments, different sorts of patients, different settings. By that I mean whether treated in a hospital or in an outpatient clinic or a doctor's consulting room or even at home. You know, it can be used anywhere. It doesn't, so now this is where it gets a bit more contentious. I think that bit is a technical requirement, but in this job specification I have for this measure, I think to fulfill my objectives, it has to incorporate the salient features of health related quality of life as perceived by ordinary people. It starts from what the sociologists would call lay concepts of health, not professional concepts of health, but ordinary people's concepts of health. So it has to go back to that. Now, that's a controversial matter. It seems to me self-evident that that's what it has to do, but not everybody thinks so. I think it has to reflect the valuations of ordinary people, and that's an issue I'll come back to a bit later on about who are these ordinary people. Okay, I've used the term ordinary people deliberately to be appealing, but there's some tricky questions to come later on about which ordinary people. So I'll come back to that later on. And finally, and this is again, as far as I'm concerned, a technical requirement, it has to be reducible to a single number. Now, that is necessary as a technical matter in cost-effectiveness studies, because in a cost-effectiveness study, you've got to finish up with a ratio of the incremental cost to the incremental benefit. And you've got to come up with a number at the top and a number at the bottom. Just one, not 20 numbers, just one number at the top and one number at the bottom. And so consequently, the effectiveness side, I'm not bothering with the cost side here, the effectiveness side's got to come up with a single number. Now, people get very worried about that, and they say, oh, it's too, how can you come up with a single number? It's just not on. And I say, well, we have to. And they say, well, I prefer to see it as a profile. I said, okay, so you see it as a profile. Now you're going to make a decision. Some of these things have gone up, some have gone down. What you going to do? Well, I'll exercise my judgment. I said, oh, no, you're not. You see, because that would be antipathetic to what I'm trying to do, because your judgment is not the judgment of of the ordinary population. And that's what I want in there. So I've got to face up to the issue of trying to get a set of valuations that I can legitimately claim represent the values of ordinary people, which is extremely difficult to do because ordinary people don't all have the same values. Okay, but I'll come back, that's a little technical point which I'll come back to later on. Okay, so it's got to be reduced to a single index scale. And the toughest bit, of course, is that it's got to embody both the value of additional life expectancy and the value of improved quality of life. Well, this is another thing that many people say, you can't do this. This is ridiculous. I mean, you can't compare life and death with quality of life. They're totally incommensurable. So I say, well, suppose you have an opportunity to have an operation which will improve your mobility and reduce pain enormously, and I tell you the perioperative risk is 5%. Think, you're going to do it or you're not going to do it? Well, you have to think, don't you? You have to think about the value of survival versus the value of improvement. If you say, I would never risk my life or anything, I said, well, how are you ever going to cross the road? I mean, it's a real problem. So people actually do make these trade-offs in everyday life. They don't think about them very clearly, and they often make very foolish ones, judging by the way people overtake on the highway. So I don't see them as incommensurable. I think that people do have to do it. They do it, okay? And so I'm going to do it, okay? That's it. It's not impossible. It's not in principle wrong. It is difficult, but that never held me back. So I think that is the essence of the QALY. That is the step that distinguishes QALY measures from all other measures. And if you say, what is the essence of the quality adjusted life here? It is that it integrates length and quality of life into a single measure. Okay, and it's that's what distinguishes it from all other measures of health. Right, is everybody still with me? I mean, you have every right to be suspicious, but okay. Right. So the quality adjusted life here. Well, the quality adjusted life here started as a sort of quite simple idea. Many people said that they think I invented the QALY, but I think I invented the QALY in the same sense that Christopher Columbus invented America. I mean, he discovered it lying there underutilized, and subsequent people found very useful things to do with it. And I think I feel exactly the same about QALYs. I mean, I found them lying around underutilized, and ever since then I've been promoting their use right, left and center. Quality adjusted life here. It starts off with the intuitively appealing notion that if we can give people an additional year of healthy life expectancy, that's great. But suppose the best we can do is to give them an additional year of rather unhealthy life expectancy. We don't really want to count that as being as good. So let's adjust its value downwards somewhat. And we adjust its value downwards, the worse we think the state is. And that's the quality adjustment bit. So we finished up with quality adjusted life years. The more unhealthy, the lower the quality. And as a convention, and purely as a convention, we set being dead as 0 on this scale. And that is just a convention, but it's a very useful convention, because if medical care kills somebody, it's reasonable, I think, to say in ordinary speech that it was of no value. Okay? So I think, although it is a measurement convention required by the system, it also has some intuitive appeal. The interesting additional element is that this is not a scale which runs from 0 to 1. It's a scale at which 0 to 1 are 2 anchor points, but it's possible to have states with negative values. That is, it's quite possible to conceive of states being worse than being dead. Okay? And it's very important to keep that in play, because in the survey work we've done, often a third or more of the population will rate some health states as being worse than being dead. Okay? And I think that's something we have to keep theoretically open. So people often loosely say that QALYs operate on a scale that runs from 0 to 1, but that isn't true. They operate with scale points where dead equals 0 and healthy equals 1. The snag with it is that healthy is not a clear concept. Okay? It's a very fuzzy concept, what healthy means. And it's usually taken to mean not having any of a list of bad things. If you don't have any of this list of bad things, then you're healthy. Okay? And that's not very satisfactory, but it's the best we can do. Because if you work on the other extreme and go over to crazy statements like the World Health Organization made about health being a state of complete physical, spiritual, material, and whatever well-being, I mean, this is about human welfare. It's not about health. It's about everything under the sun. And it's totally unattainable by anybody. So, and it sets impossible targets. It means we all have to finish up, you know, on drugs that keep us in a permanently euphoric state, which isn't terribly appropriate, I don't think. So that's at a sort of low conceptual level, but high intuitive level, I think the QALY is a very appealing notion, and the things we're seeking to do with it are also very appealing. Anybody wish to disagree at this point? I mean, do jump off this bandwagon whenever you feel inclined. Now, the next thing, I'm going to have a slight diversion now because I want to talk a little bit about how I would use it. I'm still deferring the issue about how the hell I'm going to calculate it, but because I think it's important to demonstrate that it's worth putting some effort into because of its incredible usefulness. My first serious essay into applying this concept was about coronary artery bypass grafting in a conference that took place in 1984, which eventually got written up and published in 1985. And this was an issue about how beneficial was coronary artery bypass grafting for people presenting with different manifestations of coronary artery disease. Now, I'm not going to talk about all the manifestations of coronary artery disease, I'm going to pick on one. And this is severe angina with left main disease, which is the most severe form of the condition. And at that time, and I don't think things have changed very much. Most people in Britain would be on a drug regime, and they would be severely restricted in their physical activities, and they would often be in a lot of pain. So they were in pretty poor shape. And just take my word for it at the moment that they were on the scale just above 0.3 on the QALYS scale. Just believe me. That is to say, they were just above 0.3 on this scale from 0 to 1. And their life expectancy was about 5 years if they stayed on the drug regime, and they would be going downhill the whole time. Okay, so, and that's what that lower bit represents there. That is their prognosis with the drug regime. Now, a successful coronary artery bypass graft would bring them up here. They'd be as good as new for a few years, but coronary artery bypass grafting doesn't cure coronary artery disease. It just relieves the symptoms thereof, which is quite an important thing to do. And then the disease will reassert itself, and the people will start going down again, and by the time they get over here, about 8 years further on, they're back where they were at the beginning. Okay, now it is possible to think about further coronary artery bypass grafts, but I'm ignoring that for the time being. We started off with typically a man aged about 55. When we get to about here, we're talking about a man in his early 60s. And anyway, and life expectancy increases from 5 to 10 years. And so if you wanted to talk in QALY terms about the benefits of a successful coronary artery bypass graft, what you would do is you'd be measuring that dark area there. Okay, that dark area is the QALY gain from a successful coronary artery bypass graft for a patient with these characteristics. And then for patients with other characteristics or other manifestations of the disease, there will be other profiles, and we could do one for each one. And you notice that it's partly a product of extra life expectancy, it's partly a product of improvement in quality of life. It doesn't distinguish the two. I mean, it's all in there, and that's it. Now, I've carefully said at each point that were the benefits of a successful coronary artery bypass graft. Not all coronary artery bypass grafts are successful. In fact, at the time when I did this study, and I don't know whether it's changed or not, 30% of coronary artery bypass grafts were not successful, in the sense that, for reasons unknown, despite the graft, people were back on the original trajectory. Okay, they have the operation, but they continue along here. Doesn't relieve the symptoms and doesn't change anything. 30% were in that situation. It's also unsuccessful in another rather more devastating effect. 3% of people died perioperatively. Okay, so the gamble you face if you are this kind of patient in this situation is you have a 67% chance of winning this prize. The stake is a 3% chance of losing that, which you could have had if you'd stuck with the drugs. So the question is it worth a 3% chance of losing that in order to win a 67% chance of winning that? And no doctor would hesitate to recommend a patient to have this treatment in these circumstances. And even I, who am extraordinarily antipathetic to medical treatment and particularly to surgery on me, I think I would have gone for it. Okay, I would have gone for it. Now, of course, in the British context, there are also costs to be considered. So there's a question about whether we think it would be worth the money to offer people this, and that also I looked into. The costs of a coronary artery bypass graft at that time were about £3,000, which is about $5,000. It'd be higher now, but I mean, not a big sum. And the quality adjusted life years gained were very high. So I came to the conclusion as well to this study that this was a good buy. This was a good buy for the NHS, and we should do it for this class of patient, but not for all classes of patient, and not for all manifestations of the disease. So I had a more graded and nice little league table. Right, that's where I started, with some very phony data, which nobody has yet managed to improve on. So the whole system works on phony data, I've concluded. Right, is that all? Is that clear? Okay, so that's what I want to do with these QALYS, you see. But of course, I don't just want to do it for coronary artery disease. I want to say, well, what about coronary artery bypass grafting versus, shall we say, hip replacements? Hip replacement. Well, here's a different story. Hip replacement. Hip replacement, we're now talking about a woman aged 65 probably, and she's got about 15 years life expectancy with increasing pain and increasing disability. She starts off at the same rating as the guy with the coronary artery disease, but her prognosis is a rather elongated version of his prognosis. I mean, but the hip replacement won't typically make that person fighting fit. They still have some deficits here. And then after, well, at that point, after about 8 years, it was likely that the prosthesis would break down or the hip would break up or something. I think they've managed to make them last 10 or 12 years now, so it's a little bit better than it was then. And then when it breaks up, there are all sorts of problems. It is feasible to do a revision and have another crack, but you're then talking about a woman aged 75 and not in such good shape, and so may not be such a good bet. This operation also has all these probabilities associated with it, which I won't bother to go into. And, but notice here, the gains are entirely in health-related quality of life. They're totally to do with the relief of pain and the improvement of mobility. Osteoarthritis of the hip is not a life-threatening condition. Now, that's a very important observation, because if you say, as many people say, that life-threatening conditions should take absolute priority over the rest, you would never do hip replacements, ever, because it's not dealing with a life-threatening condition. But the improvement in health that you can bring about with a hip replacement is enormous, absolutely enormous. And it's not a terribly expensive operation, at least we don't think so. And I mean, we're strongly into the idea of doing things that are not terribly expensive. So, with the operation, not very great now. Partly because we're very selective in who we offer it to. Okay, that brings down the mortality rates terrifically if you don't ever give it to anybody over the 70 or anybody who's got cancer or anybody who's got any other stack of things. So if you're selective enough, you can bring mortality rates down quite a lot. But in the process, you deny a lot of other people the benefits of treatment. It's a nice trade-off. I did a lot of work on the waiting lists for general elective surgery at Guy's Hospital in London. The 5 surgeons there working, in inverted commas, together had well over 1,000 patients waiting for surgery when we worked on their waiting list. And 300 of them were waiting for the surgical removal of subcutaneous lumps. Now, subcutaneous lumps are not a big issue, really. They're a bit distressing for people who have them, and they'd like to get rid of them. But it's an extremely boring thing for surgeons to do. and they put a few in at the end of an operating session if there's a bit of space left. But anyway, we tried to find out what. Now, subcutaneous lumps are not life-threatening, and they're not seriously interfere with people's quality of life unless they happen to be in some part of the body where it's a bit disfiguring, so they won't go swimming, or they won't do this, or they won't do that, because they don't like showing this horrible deformity which they think they've got. So there's some small impact on people's quality of life. But these people have got quite long life expectancy. I mean, the typical age of people waiting for this were people aged 35 or 40. And so they had long life expectancy, a very small gain, but it's incredibly cheap. Okay, I mean, it cost almost nothing to remove subcutaneous lumps. So we went back and said to them, well, look, why don't you this is a very cost-effective thing to do, and you've got 300 of them on your inpatient waiting list. I said, well, they occupy typically 2 bed days, okay? But so I said, well, why couldn't you do them as day cases? I mean, why should they be coming into hospital at all? It's ridiculous that you should have all these people on. I mean, maybe they don't all need it. A year later, they had, I think, 3 people left on the inpatient waiting list because they'd switched the whole thing out of inpatient surgery completely. Now, generally speaking, I'm opposed to Hawthorne effects from investigations, but I think in this case the Hawthorne effect was terrific and very much in the public interest. Again, QALYS revealed things to the people who should have known, things that they didn't know. Here's a very different story. This was surgery for advanced lung cancer. This data is phony. This is completely invented data, unlike the other data, which is only partly invented. Here I invented a case which is approximately true, that surgery for advanced lung cancer makes people's health-related quality of life, which was already bad, still worse for a short period by giving them a very short additional time of a very poor quality life expectancy. So on balance, there's nothing in it, really. And this is approximately true, and so we don't engage in surgery in this circumstance anymore. But I only put that in to show that the QALY can pick up this kind of situation as well, where treatment makes you worse. And it's very important, for example, I think with chemotherapy, for example, not simply to evaluate what happens when the treatment is over, but to start the evaluation at the point at which treatment begins, because the actual process of treatment may be so devastating that it really isn't worth it. Okay, and that's why I put that in. And I'll show you a real life one a bit later on with real data. And then my final essay in all this QALY business was provoked by people saying, well, this QALY stuff is all very well, where you're dealing with things that generate clear improvements in people's health, but what happens when there's no way you can actually improve people's health? So I said, well, what do you mean by improving people's health? Do you mean absolutely improving their health, or do you mean improving their health relatively to some other situation? Because QALYs are really only about improvements relatively to between different alternatives. And here this is concocted data. This is concocted data. I think this years is a mistake here. We should have months here. But suppose you've got a situation in which somebody is going downhill all the time, you know, terminally ill patient. And there's no prospect of curing them. But there are things you can do with pain relief and counselling and so on to reduce anxieties, to enable people to come to terms with the fact that they're dying, to relieve the pain, to help relatives deal with this situation, so that people can die more calmly and in a sense more in control of their situation. Now, my point here is that even with the good palliative care, in inverted good palliative care, people still go downhill all the time. Nobody ever got better in an absolute sense. They went downhill, but they didn't go downhill so fast, and they didn't go downhill so much. Okay, so the benefits are again the shaded area. So the benefit of providing such people with good palliative care could be considerable, okay? Quite considerable. Even if you do nothing for their life expectancy, it can still be a considerable benefit. And the benefit, as I say, consists of reduction of pain, reduction of anxiety, a better capacity to cope with family responsibilities and etc. So the QALY is the point of that little excursion was to demonstrate the extraordinary versatility of the QALY concept. Okay, convinced? Good. Right. Well, then we have the prioritizing rules which flow from that, but I won't bother with those. Well, perhaps I will. What comes out of this if you set up these cost per QALY league tables? I'm not dealing with the cost side at all, but there's some tricky problems on the cost side as well. Whenever the opportunity arises, redeploy resources from activities that yield high cost QALYs towards those that yield low cost QALYs. So that's where this rationing priority setting game begins to play. You seize your opportunities to shift resources around. The exception is when I've got lost of transparency here. I don't know whether you have it, but there should be one which said that it is legitimate to also to support some activities which generate high cost QALYs if reasonable got a bit messed up, if there's a reasonable prospect that the activity yielding high cost QALYs will soon manifest improved effectiveness or reduce costs. Now, at the time when I did my original work in 1984-85, I was amazed at how well heart transplantation showed up. At that point, heart transplantation was regarded in Britain as a very experimental way out thing to be doing, whereas kidney dialysis was a fairly routine operation. I came to the conclusion that on cost per QALY grounds, heart transplantation was twice as good as kidney dialysis. So we should be shifting resources out of dialysis and into heart transplantation. But people said, well, there are lots of other things like kidney transplantation used to be a high cost, low effectiveness activity. They found much better ways of doing it, and it's now virtually routine. I mean, we would transplant every kidney we could get hands on, you know, and the problem now is how to get hands on more. I mean, so maybe the same would happen in the end with brain transplants and whatever else we think of next. But these high cost things, which people say they wish to support, because otherwise we will stifle innovation and progress, I think we do have to support. But there has to be this reasonable prospect, and it should be paid for out of research funds, not out of the mainstream health budget. Okay, very important. And as a research activity, it should be subject to a peer-reviewed protocol, okay, not just done casually. All data to be disclosed, not just the successful cases wheeled out and paraded, forgetting about the others. Evaluated by independent researchers, not by the enthusiasts, okay, which again, and so these are quite stringent criteria which are infrequently observed in practice. Usually one or more of these is breached. Okay, so that's the kind of analytical work I would like to see done, and it's the kind of framework in which I would like to see things evaluated. So we finish up with the incremental cost per quality data. Yeah?
You might address this later, and you probably have thought about it. I'm just curious how you incorporate it in this. So you have several cases which, when you add things up, yield the same amount of QALYS, but they have a different time dimension to them. One of them, many QALYS at the beginning, another one, they show up near the end. How do you
it's no problem for an accountant. No, it's no problem for an economist. I mean, we have discount rates.
No, I know. I understand that.
We have discount rates. The only question for me is, what should the discount rate be? I know it should be positive, but I'm not sure how big it should be, and I'm quite happy to go along with the recommendation of the US Public Health Panel, edited by Martha Gold and others, Milton Weinstein, which recommended 3% as the rate to be used. 3%, of course, being a real rate. So it's applied on the benefit side. It's not a problem because we value the benefits always in real terms, but on the cost side, it may need inflation taking out before the 3% is applied. But I don't have any problem with that. There are, however, quite a lot of conceptual problems about whether where this discount rate decision should come from. In the context of a national health service, it really isn't much of a problem because it's a national policy decision, the 3%. It gets a lot more difficult if you're talking about trying to reflect the time preference of individual patients or something, because they may have quite different views. But from a point of view of collective decision making in a national system, you can sweep all that aside, and whether you like it or not, it's whatever the cabinet decides it is. Right, any other complications anybody worried about I'm not taking into account? Okay, right, so now I've got to get into, I can't put off any longer getting to grips with how I'm going to do it. I've tried hard to get you to sleep before I get here, but it looks like I've failed. Right, now, I don't think that the measurement of life expectancy is a thing that exercises people very much, so I'm not going to talk very much about the measurement of life expectancy, though it is in fact very tricky, and it's full of assumptions that are probably invalid. And we don't have detailed information of the kind we would like to have for different subgroups of the population. So the measurement of life expectancy is not in fact unproblematic, but I'm going to ignore it just the same, because I think the really tough issues are on the quality adjustment, not on the length of life issues, but on the quality of life issues. So I'm going to concentrate on that bit of the problem. And there are different, HRQOL is health-related quality of life. And and in economic evaluations, there have been arguments about how specific or generic they should be, whether it should be profile or an index, and what the type of scoring system is and its scale properties. And there are big arguments here between the economists and everybody else on this issue, because the many epidemiologists and psychologists don't like the restrictions which the economists place upon this kind of work. They feel it's much too restrictive. For example, from the economist's point of view, it has to be generic, That's because we're trying to compare things in very different fields, as I just did. So I don't want any specific measures. Has to be generic, has to be an index for the reason I mentioned earlier, and it has to have the 0 to 1 interval scale. It has to. So from an economist's point of view, these are non-issues. Okay, the rest of the world can go and do what the hell they like, but we won't take any notice of it unless it fulfills these requirements, because these are necessarily logical requirements for what we're doing. Okay? And they actually make life more difficult for us than for other people. So it's not something, it's not an easy get at. So that bit we can dispose of rather quickly, and it means that measures, very popular measures like SF36 are in principle out from our point of view. SF36 is wrong for a whole variety of reasons, one of which is it doesn't have any values in it from the general population. In fact, it has nobody's values in it. Which brings me to whose values. And here is another big area of contention. Should the values that go into these things be those of experts, like these people might all be claimed to be experts, philosophers might even claim to be experts in value systems? I say no. I say it has to be the general public, but it's perfectly legitimate to argue that it should be one or other of these people on the grounds that they have more experience of these things, they see more of all this, they're better, they've had the opportunity to think through the consequences better than ordinary people have. So ordinary people don't really understand these things, so let's concentrate this on the grown-ups and not let the children make these decisions. I mean, that kind of thinking. When we talk about lay people, this comes back to my earlier point. I said I'm talking about ordinary people, but who are these ordinary people? Well, here's a list of possible ordinary people: patients, taxpayers, citizens, struggling humanity in general. I mean, who are these ordinary people? Okay. Now, I think it's very tempting for clinicians and other people working in the healthcare system who see themselves as forward-thinking people reacting to consumerism, it's the patient's values that count. But I say, no, that's not right. It's not the patient's values that count, it's the citizen's values that count. And then they say, but they're the same people. I said, yeah, but they're playing different roles. Okay, when we are thinking about how much money we want to spend on healthcare and what our priorities are, when we're thinking of citizen taxpayers, we're thinking one way. When we're patients, when I'm a man aged 55 with heart disease, I don't give a damn about the people with cancer and orthopedic conditions and so on. It doesn't interest me. All I'm interested in is heart disease, okay, and what can be done for me. So when I'm a patient, my priorities shift markedly from when I'm thinking about it as a citizen with no known, at that point, no known interest in the system. So I think that it's very important that it be the views of the citizen taxpayers that we try and tap into, and not the views of particular patients in a need-driven system. Because we're not in the business of pleasing individual patients, we're in the business of maximizing societal health according to societal values. So I have to say citizen taxpayers. Now you could say, but that's ridiculous. The citizen taxpayers have already voted for elected representatives. So why don't I simply say, well, just get the views of the politicians? And I say, they won't give them to me. Not in a form that I want them. They're denying that this whole problem exists. I mean, what's the good of going asking the people how to solve a problem that they say doesn't exist? And anyway, I don't think a good many politicians actually know in detail. For example, if I ask them, the typical politician, how important for people is the relief of pain compared with the improvement of mobility? Give me a number. But that's what we need. We've got to have numbers like that. So I'm not interested in the elected representatives. I can do better than they can do in eliciting the views of the citizen taxpayers on these specific issues. So I'm not really interested in what they think, except to contrast it with what the general public thinks. And I'll say, this is a tricky set of questions, and the QALY concept itself doesn't require you to answer the question the way I answered it. You could calculate QALYS based on doctors' values, nurses' values, managers' values, priests' values, anybody's values. But you better be specific where your values came from, so that we all know where they came from. And the DALI concept, generated by the World Bank and the World Health Organization, the guy Murray who generated that work, he went for experts. And so his set of values come from experts of various kinds, across many different nationalities and very, very different disciplines. So what he has is a view of a large number of very varied experts. But that, in my book, is still a long way off the values of ordinary people. Okay, so that's where I stand. But you don't have to stand where I stand on this particular issue. Okay, I'll move on.
I don't know if we'll get to this, but we've had some interesting conversations over the past few days on this point or other fora, and the idea about whether whatever it is that maybe smaller, more homogeneous groups of lay citizens, taxpayers, might be more appropriate than trying to assign it across a huge homogeneous society.
Yeah.
The U.S. Do you want to comment on that?
Yeah. Well, if you run a national health service and you want to deal with all people on equal terms, you've got to find some way of aggregating and averaging the values of the whole community. No? And in some countries, for example in New Zealand, which I'm quite interested in, you have two very distinct populations. You have the Maori population and the non-Maori population. The Maori population actually has a different concept of health from the rest of the population. It's a much broader concept of what health is. So it's a bit difficult then to say, well, we're going to treat all citizens in New Zealand equally. We're going to apply the same concept of health to all of them. So they finish up having a Maori health service and a non-Maori health service. Well, then there's endless argument about who's getting an unfair share of the resources and discriminatory behaviour, and then they're trying to do national priority setting, and the big issue is should the national priorities be set irrespective of whether people are Maori or non-Maori or whatever. Okay, so you can get in difficult. Now, what I would say, because of the difficulties involved in coming up with some central measure of value in a community where individual values are very diverse, it's a great advantage not to work with a big agglomeration of people. And if you can break them down into more homogeneous groups, that's a great advantage. But I think if you're dealing with, as we are, a national health service, or as the World Bank is, distributing money all over the world, it's very, very difficult to break down the system so it operates in different ways with different people. So I think there are really severe problems about the appropriate notion of community in all this. I think it cropped up a little bit earlier with employers being interested in their own employees and not with anybody else. I mean, so they see even if they adopted this system, they would see the target population as being a subset of the entire population, and that would be it.
I did think it was interesting, though, in our conversation, the observation that perhaps it is a small, homogeneous place like Oregon and a small, homogeneous place like New Zealand, where some of these ideas have kind of moved a bit further into policy discussion, albeit not fully developed yet. I mean, I think that's a very interesting observation.
Yeah. Okay. Whose values? Now, the Washington panel, which I referred to earlier, identified four extant measures as satisfying the conditions that work for what economists want to do. The Euroqual, EQ5D, the Health Utilities Index, which is a Canadian measure, Quality of Wellbeing Scale, which was the version that Oregon started with, and the Years of Healthy Life, which, although they think it fits, I don't think that fits at all, really. That's an attempt by public health people to use existing data in this way, and I don't think it's sufficiently discriminatory, but these are the four anyway. I was involved and have been involved, and I'm still involved in the development of that particular instrument, so I know more about that than anything else. I'm going to talk about that, but the Health Utilities Index from McMaster and the Quality of Wellbeing Scale are the other players in this game as far as I'm concerned. And you've got in your pack of stuff some Euroqual material, so you can see where I'm coming from in all this discussion. But there are other places to come from besides that. Well, I won't bother with that. And I won't bother with that. Now, I think when you get into this quality of life measurement business, it's really quite important to separate what you use as a descriptive system from what you use as a valuation system. And in the Euroqual system, we did a survey of lay concepts of health in the West Midlands of England, asking people simple questions like, how are things different for you when you're ill than when you're well? And then just listen to what they say. And they say all sorts of different sorts of things. And then you ask them, well, what are the most important things about illness that really upset you? I mean, what are the things that are really important? And then they say various things. You know, they hate pain, or it's not being able to look after the children, or whatever it is. And then we got a little bit further, and we said, well, here's a list of things that people have said, other people have said are important in all this business. Are any of these? How would you rate these as well? And so you get a few more things, and at the end of the day, you get people. Then at the end, you say, well, now would you rate these different things in order of importance for you? And so, and out of that came a list of concerns, the 5 that are actually in the Euroqual system, which are worries about mobility, about self-care, about the capacity to get on with your usual activities, whatever they happen to be, the problem about pain and discomfort, and anxiety and depression. There was another one actually, which was tiredness. Many people associated illness. One of the important things that they were tired, lethargic, and that was a bad thing. We actually had a 6-dimensional system for a little while, but it turned out that that was so highly correlated with all the other things that we dropped it, because you want to make these things as parsimonious as you possibly can. Okay, so that's the descriptive system. Now, of course, you can't really separate description from valuation, because if you decide to drop something from the descriptive system, you've said it's of no value. So the valuation issue creeps in by the back door through the decision not to include something. There's also a problem about this, well, I'll just mention it briefly en passant, that clinicians often want a level of detail that's really quite inappropriate for economists' purposes. So there's continual tension between clinicians trying to make things more and more detailed, and the economist's notion to keep the whole thing handleable. And this turns on the number of cells in the classification system that you finish up with. The Euroqual method, which has 5 different dimensions, each of 3 levels, generates 3 to the power 5, which is 243 different theoretically possible health states, to which you've got to add unconscious and dead. Okay, so you've got, now the Health Utilities Index generates 9,000. I dealt with, when I was working on multiple sclerosis many years ago, with the Kurtzky Index. The Kurtzky Index generates 40,000 million different cells, which is more people than exist in the world with multiple sclerosis. And so vast part of this system is just empty. Okay, well, it isn't worthwhile collecting information on that scale if most of it you're never going to use. So, and I always think that 245 is rather large, but it can't be, it can't. If you want to make a health state classification system capable of being used by ordinary people, then it's got to be something that ordinary people can just complete very simply, without having a researcher standing over them, guiding them as to what they're doing. So some of the while people are sitting waiting to see a doctor, you just give it to them and say, would you mind filling this in for me, you know, and they can do it in no time at all and hand it back to you. And the Euroqual system was designed specifically with that in mind. Now, of course, that means that it's really not suitable for use in people who are not capable of responding. So it, like all self-completed measures, it has that important limitation. It can be filled in by somebody else acting on behalf of an individual, but then it's a bit suspect, because that gets me away from what I really want, which is to find out what the people themselves think about what's happening to them. Well, I've already told you those dimensions of the Euroqual system, and you'll find in the next 2 slides the actual levels that we use, and they're in the questionnaire which you've got, so I won't waste time going over that. Now, but the next bit is interesting. Somebody said, I forget who it was now, in the opening discussion about being interested in the use of quality of life measures in measuring population health. Was it you, I think? Was it? Anyway, somebody was interested in measuring population health. Well, now we did a survey of 3,000, just over 3,000 members of the British general public who were interviewed in their own homes. Quite a long, elaborate health questionnaire. It took about an hour, just over an hour to complete. And in the process, we collected at the early stages, we got them to complete the Euroqual questionnaire, just tick the 5 boxes. And so, without doing anything fancy about valuation or anything, or building up QALY indexes, we discovered some quite amazing things. For example, in the British context, social class is a terribly important thing. Social classes 1 and 2 here are the professional and managerial classes, like us. And these are unskilled manual workers, and these are the people in the middle, okay? And along here are the 3 age groups. This is under 40s, 40 to 60, over 60. People reporting problems with mobility. Up to the age of 40, there is absolutely no social class gradient whatever. By the time you get to the 40s to 60s, a social class gradient has emerged, and it persists here. But of course, the big jump with problems with mobility is a product of age. So people over the age of 60. Okay, enormous jump. Look, the people in social classes 4 and 5 over the age of 60, over 40% of them are reporting problems with mobility. Now, this is not a population of ill patients. This is the general population. Okay? 40% of people over the age of 60 are reporting problems with mobility. Okay. Now, we've done lots of surveys of disability in Britain, and there was nothing surprising about that finding at all. Nobody was at all surprised. But we don't do surveys of pain, okay? People don't do surveys of the prevalence of pain in the community. I don't know whether there have been any done in the United States, but there haven't been any done in Britain. Well, one of the dimensions we picked up on pain was on pain. And look what we discovered. Social classes, social class gradient in pain, even for the under 40s. Even more so in the middle age and in old age. Look at this number here. 60% of the people over the age of 60 amongst manual workers' families report experience of pain. 60%. Yeah. There's a big health deficit here requiring some attention from somebody. I mean, the doctors I talk to say pain is controllable, they say. Is it? 60% with pain. Pain is controllable. Well, maybe these people don't go to their doctors with pain. Maybe they've been to their doctors with pain and been disappointed with the results. Maybe that the control of pain has such awful side effects that they don't actually want to risk it. I mean, maybe there are good reasons why they're all there. But it seems to me this is an issue in population health which isn't really addressed. Pain clinics are an exception in the British healthcare system rather than a regular thing. And so...
Alan, if you've broken that stuff down, either here or in other publications, say on the pain dimension, you know, the
Yeah.
three, because I know people looking at it would be wondering, well, is that real sort of minor pain, or on this no problem, some problem, or extreme?
Yeah, it's
fire on the pain.
the bulk of it is the middle category, is not the extreme category. Okay, so it seems to me there's an argument in this measurement of health-related quality of life of doing some rather simple things that the QALY approach directs your attention to before you get onto the really tricky things about how do we construct this index. Okay, because I haven't constructed any index yet. I've just listened to what people tell me and counted it up and written it up. Okay.
Are you going to address the ways to alleviate pain? I mean,
No.
Presumably, well, but wouldn't that be necessarily part of your measure? Do you mean if you were going to consider?
Not me, no. I want to measure, if you think there are good ways to reduce pain, then I use my measures to find out how successful you are. But it's not my business to dream up ways of doing it.
Well, no, that's what I was referring to. But when you have multiple ways of reducing pain.
Well, then I would want to say, well, look at the options, and we look at the cost effectiveness of different ways of addressing this pain issue.
Pool all those. I mean, you have one dependent or objective of reducing pain.
Well, no, I would always want to use the whole generic measure, because it may well be that for many people, if you reduce pain, you would actually improve their capacity to get on with other activities, you would reduce anxiety, you would do an awful lot of other things. And so I wouldn't want just to look at the pain dimension, because I'm into generic healthcare. I'm into generic measures of healthcare. So I suspect that the people who are in a lot of pain are restricted in other ways as well, on other dimensions. Well, pain creates anxiety, doesn't it? And pain reduces your ability to get out and do things.
I thought she might be asking from a capacity to benefit from
Yeah.
almost.
Ah.
There are certain pain, if there's imagine certain pains that are almost not relievable, do they sort of count as much in a capacity to benefit?
Well, no, they wouldn't. But you see, what I would want to do, if you came up with alternative plans for dealing with this situation, I would say, okay, well, apply these EuroQAL measures beforehand, apply them again afterwards, and compare the level of benefit that you get on the EuroQAL scale from these different things, like I would have done with palliative care, for example. You have a plan to relieve pain, compare it with what happens at the moment, and we'll see how it scores in a QALY context. That's what I want to do. But I'd also want to look at the costs of these different programs as well, which I'm not talking about here. Yeah?
Were these just people from the West Midlands, or did you interview people in Greece and Bulgaria and so on?
No, I've not interviewed people, not on the lay concepts. That was only the lay concepts business. The evaluations we got from the whole of the UK, not just in one area, and other members of the Euroqual group is an international group, and the people in the different constituent countries have done surveys of values in their own countries. So the Swedes have done some, the Dutch have done some, the New Zealanders are doing it at the moment. I've got Japanese values, all sorts of different countries have done the valuation studies. So, and we're still in the business of trying to compare the valuations, although it's quite difficult because you're never absolutely sure that the translations that you're using are so accurate that the differences you're getting are strictly differences in underlying views or differences due to very slight changes in the connotations of the word. No matter how hard you struggle, there's always a suspicion that you're not asking questions in exactly the same way and triggering exactly the same response. So the international comparisons are a little bit tricky, I think, but this isn't based on it. I think it's important that each country should generate a set of values for itself, okay? Even though I think deep down the human beings have more in common with each other when you get to this level than any cultural differentiation would occur. I don't believe that, well, I better be careful because it appears from the preliminary data I've seen on the Japanese survey that the Japanese are a lot more stoical than the British. Okay, and that doesn't actually surprise me because I don't think the British are a terribly stoical lot. Okay, I better get, oh boy, yes, I better get to the crunch. When we get to the valuation game, this is where it gets really difficult because there is no gold standard when it comes to getting valuation, none whatever. And there are many ways of going about it, and unfortunately they generate somewhat different results. Okay? So we're now entering an area where there's plenty of room for commitments of faith, as it were, which are untestable scientifically about which way you should go. Now, the main alternative ways of doing things are rating scales, you know, where you give people a line to draw on and it says terrific at one end and awful at the other, and they rate something somewhere in between. Now, we don't actually, the terrific and awful is a joke, but you do that kind of thing, or you get people to tick boxes about how good or bad something is. Those are the rating scales. There was a method used in the early days called magnitude estimation, which has fallen into disuse now, I think, because it's so precarious, where you ask people questions about how many times worse is this than that. And once you start asking people a whole chain of things about how many times worse something is than something else, the capacity for distortion is just enormous, and that has fallen into disuse. But those two methods were methods which the psychology community was very fond of, and this one they still are. These three methods are methods that economists are very fond of. And I use this like a love relationship because it comes very much out of the respective cultures of these different communities. Obviously, you'd expect economists to be interested in willingness to pay. This is the stuff of life for an economist. So a lot of the early work was done on willingness to pay, and then it fell out of disuse because the medical profession generally and the public in general, in a context of a national health service, would take the view, we're not interested in people's willingness and ability to pay. The whole point of having a National Health Service was we got away from willingness and ability to pay. So we don't want you guys bringing it all back in again. So willingness to pay has never had a good press in the British people to do with either the British population or the practitioners in the National Health Service. So that leaves these two economists' favourite toys. The time trade-off method asks questions of the following kind. Because the QALY is made up of a length of life and a quality of life, we could ask the question, how are you willing to trade off one against the other? Suppose that you face the prospect of being in some god-awful health state for 10 years, but we could actually make you completely fit, but only for a limited number of years. Okay. Now, where would you strike a balance? I mean, for how many years would we have to make you fully fit to be this difficult for you to choose between the two? And obviously, the smaller the number of years that people choose, the worse the initial health state must have been, because you're willing to say, well, 3 years of health is equivalent to me for 10 years of this state. Or someone might say, well, I'm only willing to give up 6 months. Well, then it can't be that bad, can it? So we use the amount of time people are willing to trade off as an index of how bad the health state was, the one we specified initially. So that's how the time trade-off method works. And then the other method is the standard gamble method. Well, the standard gamble method is closer to this decision about what perioperative risks you would take to improve your health state, because now it's not how many years at the end of your life would you trade off to improve your health state, which is what the time trade-off method asks you, but it's what risk of immediate death will you accept in order to improve your health state. So again, you postulate some god-awful health state last for 10 years. You say, but we can make you fully fit, but we may kill you. Now, what risk of immediate death are you willing to take to get out of this health state? And of course, the higher the risk you're willing to take, the worse the health state must be. So we play those games. And the reason why we play those games is economists think that the only way to find out what people really value is to ask them to give up something else that they value in order to get it. So we force people into an exchange situation, a trade-off situation. Okay, you can either have length of life or you can have quality of life. Or you can either have security in that you'll have this, or you can take risks. And people don't like taking risks. So those are the games we play. So those are the two favourite methods of economists. Now, there is another method called equivalence of numbers, which got retitled person trade-off, which is the method used by the World Bank and a few other people, where you say there are 100 people who are in this health state and we could make them all healthy. Now, over here, there are a lot of people in a different health state. Now, how many of those would we have to make healthy in order for the total benefit to be the same in the two cases? So you're comparing numbers of people for whose health you can change in one way with a fixed number of people who are the sort of numeraire in another one. And the argument in favour of that method is that ultimately, in a priority setting in healthcare, you're actually choosing between benefits to different sorts of people. So we better have the people up there. The other methods are asking about people's values of their own health. They're not asking questions about its distribution between people. So the alleged advantage, and I say alleged because I don't approve of this method, the alleged advantage is that it allows you to take the distribution of benefits between people into account, as well as how bad the health state is. Now, I think that's bad because I think we need to know about the value of the health states independently of the way we distribute the health benefits between people. And I'd rather keep the two things entirely separate from each other, which is a point I'll come back to tomorrow when I talk about equity in the distribution of health. But I prefer to keep the two separately. So from my viewpoint, these are the two key methods, though we have also used that one as a sop to the psychologists. I always had psychologists in my research team, so you have to try and please everybody, don't you, to keep them happy. So we've always had the rating scales in there. And I've come around to the view that you can actually do a lot with rating scales if you choose to, but you've got to be very careful because people aren't making trade-off decisions. Right, now those are the sort of methodological choices. They all have snags, okay? Yeah?
Brief question about the time trade-off. It just seems intuitive to me that if you ask me a bunch of questions about time trade-off, I could probably provide you with some answers.
Yeah.
But if I were actually being in one of those states, I would have a totally different relation to that state.
Yeah.
I mean, it seems
That's
very
all right.
arbitrary.
Let me put, well, hold on a moment. There are two different issues you raise. One is whether you would trust the judgments of people who've never actually been in the state themselves. That's one. The other issue is, do you want only to accept the judgments of people who are currently in the state? Okay, these are two slightly different things, because all the experience of ill health there is out there in the population. So a lot of people have experienced bad health states at some time in their lives, even though they're not in them now. But if you say you only want the views of people in the health state now, we're in serious trouble, because we're going to get only the evaluations from patients. But I don't want the valuations of patients, because they've got special interests. I want the valuations of the general public. So you could be saying you only want patients' values, you don't want the values of the general public, or you don't believe the valuations of the general public unless they've actually experienced the state in the past. The last one?
It's not a great method.
Eh?
Or it's not a great method at all.
As opposed to?
Well,
As opposed to?
well, yeah, I should be able to come up with something better, of course. But
Yeah, I would like to come up with something better too, but I don't think we have any choice really. I really don't think we have any choice. I mean, as far as I know, there are no other methods that will generate the kind of material we need to have, which is people's views about the trade-offs between, at a subjective level, subjective trade-offs between different health states. There's a fortune to be made, by a Nobel Prize to be won probably, by anybody who can come up with a method that has all the good points of all these methods and none of the bad ones. You're doing a PhD, yes? Now's your opportunity.
Maybe I missed something fairly fundamental with me at this hour of the day. I guess I thought to understand that the rating scales and the thermometer and some of that stuff was more used to compare the valuation of the states.
It is, yeah.
The 243 at a point
Yeah.
in time, where these others are more used to value the life years versus the states trade-off. Is that?
Well, the problem, if you force people to rate things on this 0 to 1 scale, then all you really you've got the longitudinal thing by implication, because you just take each separate period and you say, well, this is the value in each separate period. So you don't have to ask people trade-off issues. So if you've got them all firmly locked into a 0 to 1 scale, you can avoid it. But the time trade-off method and the standard gamble method don't avoid it. They bring it up front, which is why economists like it, those methods, better than the others, because the issue is up front. Look, it's a few minutes after 5, and I could go on now to talk about how we use these methods. Spend perhaps another 15 or 20 minutes on that, or I could come back to that first thing tomorrow morning. Now, I think in some ways it would be better to go on for another 20 minutes, but would that going to upset anybody if I went on for another 20 minutes? Okay, let me just do that because it flows more naturally. Here is the rating scale. Let me just say that in the study that we did in York on the British population, we used three methods. We got people first of all to do a ranking. We put the different states on a card and we said, just put these in order of how they would appear to be to you, without any complicated measurement, just rank ordering. Then we got them to take these states, rank ordered, and locate them on the thermometer like that. And the important thing about this thermometer, which is not at all trivial, is the bottom of it says worst imaginable health state, and the top says best imaginable health state. The top does not say healthy, and the bottom does not say dead, okay? Because healthy and dead have to be located in this space somewhere, both of them, okay? So this is very important. And whenever I see these rating scales that have healthy at the top and dead at the bottom, I think, well, this is a load of rubbish. They haven't really thought through what they're doing. So that's a very important issue. And so what we then do with this, which is a bit tricky, but typically people rate healthy somewhere below the best imaginable health state because they have some notion of some euphoric situation, like when you fall in love for the first time, it's an awful lot better than just being healthy, isn't it? And so people typically locate healthy up here somewhere, but they keep a bit in reserve, particularly if they're using a simple classification system like the Euroqual, which you're regarded as healthy with the Euroqual if you don't have any of the bad things, okay? But there's not much positive about it. And dead, most people don't rate dead as being the worst imaginable health state. So it's not usually at the very bottom. It's usually a little way up. Now, this is a tricky point, and I'll come back to it tomorrow. Suppose we say that as a matter of social ethics, we are going to regard being healthy as the same for everybody, and being dead is the same for everybody. Now, it's unprovable, okay? You can't prove that it is, but you're saying that from a point of view of healthcare policy, that's the assumption that we're going to make. So, and if you make that assumption, then we want to rescale everybody's values so that on their particular scale, healthy is 1 and dead is 0 for each individual respondent, each individual. And then we rescale their answers on this thermometer within that rubric so that we follow each individual's answers. So if somebody put the Euroqual state 11122 means that they had no problems with mobility, no problems with self-care, no problems with their general activities, moderate pain and moderate anxiety. That's the coding system for Euroqual states. They located it there. We don't say that it's 50, say, between here and here, but we say it's 60 between here and here. Okay? So they're all rescaled so that everybody's value for dead becomes 0, everybody's value for healthy becomes 1. Okay? A very important bit of trickery, which has only to be applied to the rating scale. It doesn't have to be applied to the standard gamble or the time trade-off because they automatically generate those base points. Okay? Now, if we want to have a brief discussion of that, I think we should, because it's quite important, because it indicates that these are not purely technical issues. This, 0 equals dead, dead equals 0, and healthy equals 1. It's not just a technical matter. It has a quite important ethical content. Okay, and it makes assumptions about interpersonal comparisons of welfare, which economists on the whole don't like pretend that they're not making. Okay, but you can't pretend here that you're not making these judgments. Okay. Well, think it over, because tomorrow morning I'm going to come back to that particular assumption and ask about its validity. Okay? But I think it's important to see where it crept in. Okay, I've dealt with all that. The particular survey we did was based on 3 different systems, and we took 42 Euroqol states as the panel which we did, and we estimated the values of all the different states. And I don't really want to go into this too much, but if anybody's really interested in the modelling, you're interested in the modelling, I think, it may be, if you want to, you and I could talk about how we modelled these answers. What we got back from people, we got back from 3,000 people, the values that they attached to 42 different health states. And then we interpolated the values for the others from this data. And the way we interpolated it was by this method. We have 12 variables to explain the values. In the Euroqol system, if you start off with the no problems being 1, which it is by hypothesis, then every movement down is a decrement. Okay, so we have 10 such decrements, 2 in each of the 5 categories. We discovered that we needed a constant term. So the constant term measures the amount by which the value of a health state goes down, whichever it is. It just moves down automatically once you move away from all the ones. And we discovered, much to our surprise, that if any of them was at the extreme value, you got a downward shift in the health state, irrespective of which one went down. Okay, so this was the model we finished up with, and called the Dolan N3 model. Dolan was the guy who did most of the modelling, and N3 was the number that this variable here got, N3. Dolan produced about 50 different models, so before we came up with one that seemed to work well. And again, this isn't important. Tariff went a bit wrong there, but never mind about tariff. These are all negative. These are all negatives. Okay, and what they say is that as soon as people's health declined from at all, you got a small decrement. Then in mobility, you got, if you're at level 2, you went down this much. Level 3, you went down that much. That's not cumulative, by the way. That's from the top. So now, and see, they all go down a bit, and N3, which is anything at level 3, drops quite sharply. But notice that the particular dimension which generates the greatest decrement in health value is pain, and it's the most prevalent in the general population. Okay, and the next most prevalent is mobility, and that's the second one. So if you wanted to say which are the 2 aspects that people get most uptight about, it's pain and mobility issues. That's what comes out from this British population data. And so it seems to me, you see, so the implication is that the way I calculate QALYS, things that relieve pain and improve mobility will get high quality benefit scores. Things that, see, what people weren't so bothered about, they weren't so bothered about maintaining their usual activities. Yeah? Who cares if you're off work? The important thing is you're not in pain, okay? That's what it's saying, you know, for the working population. Did we know this before? Does policy reflect this? Is it true? Is it true? I'm pretty convinced it's true of our three. Nobody in Britain has a panel as large as 3,000 members of the general public. We have the biggest panel, set of panel data there is on this issue. The Department of Health couldn't believe this, and they couldn't believe it on the prevalence of pain and all that kind of thing, so they incorporated QALYS stuff into a national survey run by the government. Came up with the same results, so they did it again a year later, and it came up with the same results. Now, they haven't replicated the valuation study, because that's a very expensive thing to do. But if one bit of your study keeps on getting replicated, I think it adds credibility to the rest of it. And so those are the scale. That is the basis. This is the basis of the scale numbers that I used in my early diagrams with you. This is the process that generated them.
You know, Alan, I know you wanted to keep away from 40,000 million values
Yeah.
and the economy of that. But does it bother you, some of these big jumps between level 2 and level 3? I mean, they seem, you know, whereas on mobility, level 2 is point, if I can read it, point
Yeah.
6, and level 3 is point 3, point 4. I mean, that's
Yeah. Yeah.
gap in a 2, just yes or no kind of deal.
Yeah. Well, you have a trade-off problem. I mean, if you want a 5-level system, take 5 to the power 5, and it's a judgment. It's difficult. People say, how can a system which has so few cells be particularly sensitive? Well, I'll show you some data tomorrow which shows it can actually be very sensitive. And I say to people, if you don't think it's sensitive, use it alongside whatever else you want to use and just suck it and see. I mean, don't condemn it out of hand, because you may discover it's a hell of a lot more sensitive than you think it is. And the important thing is, it's extremely easy information to collect. You just hand it to somebody to fill in. They give it you back. You can summarize all the data in 5 digits, and you can computerize the scoring system, and it's easy to understand. You can produce a profile if you'd rather have a profile. I mean, it's an all singing, all dancing system. But its simplicity is both its strength and its weakness. I mean, its weakness is the one that Dave pointed out, that it doesn't look as though it's very discriminatory. But and of course, what tends to happen if you're doing a study of a drug and it comes out that it doesn't make much difference whether they give people the drug or not give the drug companies say, shoot the messenger. Okay, this is obviously a hopelessly insensitive system. Let's find something that does show, and keep on casting around until you find something that does show. This is the cynical bit of me about specific measures now talking. But I think the QALY business is not going to take off unless we can find some simple way of making it a fairly routine operation. And I think this is the closest you will ever get to making it a fairly simple, routine operation. Yeah.
Two things that strike me: anxiety and depression.
Yeah.
They're separate issues, and you're missing huge things like hunger. At least if you're ever going to expand this beyond England.
Yes. Well, is hunger a health state, or is hunger a source of ill health? I mean, it's a very nice question about where does health leave off.
It's kind of pleasure
But,
state, or there's a whole
yeah.
lot of quality of life things that
Yeah.
are missed.
Yeah.
And then, why did you put anxiety and depression in the same indice?
Because we had to. I think we experimented with a lot more separation, and at one time or another, and we couldn't generate data that separated them sufficiently in the early surveys that were done. Do you think you would get depression without anxiety and anxiety without depression?
Absolutely.
Commonly?
Well,
Okay.
clinically, yeah.
Clinically. Okay, well then I think what has to happen is that when collecting data using Euroqual, you should also collect data using more specific methods and then see when it goes awry. Okay, that's what I would say you have to do. Yeah.
Just a quick the level of correlation between those, I mean, those reporting higher levels of anxiety or depression are far more likely to decrement their pain, their status in pain discomfort.
Well, yeah, the argument is that there's a high level of correlation between the dimension of anxiety and depression and these things and the pain. Well, okay, well, we'll test it, see if it's true. Okay, I mean, I don't see any alternative but to do that. Yeah, anything else, or should we stop there?
I think it's time to stop.
I think it's time to stop too, yeah.